This lecture will concern itself with acute pancreatitis. And as usual, we have our learning objectives, which are to identify the pathophysiology of acute pancreatitis, describe its complications, identify therapeutic interventions to promote well-being in persons with acute pancreatitis, and to incorporate critical thinking. Now, if you remember, the pancreas is a slender organ about 6 inches long and 1.5 inches wide. It has 3 segments: the head, the body, and the tail. The head lies in the convexity of the duodenum, and the tail actually touches the spleen. It has 2 separate types of cells that have entirely different functions. There are the Acini cells that produce trypsin, chymotrypsin, carboxypeptidases, nucleases, pancreatic lipase, pancreatic amylase, and you can tell there's a lot of them. These actually take part in the excretory function of the organ. Keep in mind that this gland has tubules throughout the connecting acini cells with the main duct, the duct of Wirsum. This duct connects with a common bile duct at the ampulla vater before entering the duodenum at the papilla. An accessory duct, the duct of Santorini, extends from the head of the pancreas into the duodenum about 1 inch above the duodenal papilla. The pancreas also has the better known endocrine function. The islets of Langerhans produce insulin and glucagon, and they are scattered throughout the pancreas. And as you know, these are important in the maintaining of glucose homeostasis. Now, there are classifications of pancreatitis. One is mild, and that is not associated with organ dysfunction or complications, and recovery is usually uneventful. And then there is the severe form, and that's associated with decreased functioning of the pancreas, local and systemic complications, and a complicated recovery, and can have a very high mortality rate. Now, the etiology is really not known, but it is more common in those with gallstones and other biliary tract diseases, alcohol consumption, injury due to surgical manipulation, cancer, trauma, or drugs, and it has a 5 to 10% mortality, and we're going to look at some of these a little bit more in depth. Gallstones, although linked to pancreatitis, occurs only in a few patients. Theoretically, it is caused by transient or persistent obstruction of the duodenal papilla by a stone resulting from the reflux of bile into the pancreatic duct. There's also little tiny gallstones called microlithiasis, and you may have to use an ultrasound to determine the presence of these tiny gallstones to diagnose this form of pancreatitis. They can also be found through an examination of the bile obtained by an ERCP, and we're going to talk about that in a minute, and by observing shifting debris within the gallbladder. Stenosis and spasm of the sphincter of Oddi, which we talked about in a minute ago, can cause pancreatitis because this sphincter is a muscular structure that regulates the flow of pancreatic secretions and bile actually into the duodenum. Cholecystokinin causes the sphincter to relax by acting through an inhibitory neural pathway. If the innervation is disrupted by surgery or other procedures, that cholecystokinin may have a paradoxical effect of causing spasm and obstruct the biliary flow. Now, this is just a reminder. In biliary obstruction, the bilirubin levels rise. Your total bilirubin normally is 0.1 to 1.0. Now, trauma can also cause pancreatitis because it's related to the disruption of the ductal system in that pancreas through blunt or penetrating trauma. Now remember our lecture about chest trauma. At times, recurrent pancreatitis may develop months to even years after the initial injury. Now, alcohol can also cause pancreatitis because it stimulates pancreatic secretion and can cause sphincter of Oddi spasm. It also changes the composition of proteins secreted by the pancreas, resulting in the formation of protein plugs that obstruct the small pancreatic ducts. It can precipitate and contribute to hyperlipidemia, and that is a known risk factor for pancreatitis. It's kind of interesting. Research reports that for every 100 alcoholic patients, pancreatitis occurs in about 5. 15 of them get cirrhosis. You can have both cirrhosis and pancreatitis in about 1. And in 80 of them, nothing happens. These data indicate that in addition to the amount of alcohol consumed, there are unknown factors that affect a person's susceptibility to injury. Now, we're going to look at that ERCP. It is actually an endoscopic retrograde cholangiopancreatography, which is why they only use the letters ERCP. An endoscope is passed via the esophagus into the stomach, through the pylorus, and into the duodenum. The papilla is then cannulated, followed by the bile duct. Contrast material is injected and x-rays are taken. Pancreatitis can occur as a result of this procedure through overfilling of the pancreatic ducts with that contrast, and if the physician has to do repeated attempts to cannulize these ducts. Also, if you have the procedure called an endoscopic sphincterotomy, this procedure can double the risk for pancreatitis, especially in patients who have sphincter of Oddi dysfunction. The surrounding tissues are subjected to greater thermal damage, and this results in edema and possible obstruction to pancreatic outflow. Pancreatic tumors and metastasis can also cause pancreatitis in addition to drugs, as theoprene, remember from our liver transplant lectures, sulfonamides, tetracycline, estrogens, Lasix, and steroids. Now we're going to look a bit at the pathophysiology of why this disease even occurs. Now, probably as a snapshot, enzymes are activated in the pancreas versus being activated outside of it. So lipase actually breaks down fat, and if it's outside of the ductal system, it leads to a soap-like product, and this combines with calcium and actually can cause hypocalcemia in your patient. Trypsin breaks down protein, and if outside of the ductal system, can cause autodigestion of the pancreas. And that trypsin also activates elastin, which can cause digestion of the blood vessels, and that can lead to hemorrhage. Finally, leukocytes can cluster around hemorrhages and necrotic areas, cause pus to form, and possible abscesses. So if we looked at kind of a picture of what's going on here, we can start with that primary injury to the acinar cell, and you get a release of active enzymes. And that causes two things to happen. There's the release of platelet activating factor and endothelial damage. That release of the platelet activating factors causes activation of kinin and fibrinolysis and activates complement. The release of platelet activating factor also causes granulocyte and macrophage activation. The endothelial damage causes increased vascular permeability, which in itself can go way down and cause diffuse tissue injury and secondary organ failure. And the granulocyte and macrophage activation releases proteases and lysosomal hydrolases and the formation of oxygen-free radicals, which, if you remember, they run around, cause a lot of damage. So that leads to diffuse tissue injury and secondary organ failure. And that release of the proteases causes a degradation of the extracellular matrix, which goes around and stimulates more granulocytes. And as you can see, there's this self-perpetuating feedback loop, because you get the diffuse tissue injury, and that causes more acinar cell injury, and the whole thing starts all over again. Now, there are complications. We're going to look at each one of these. Fluid collections are not uncommon and only cause complications when they become infected, and this usually occurs in pancreatic necrosis. In this case, the collection is drained using those percutaneous catheters. Now, pancreatic ascites refers to the presence of large amounts of fluid rich in pancreatic enzymes. This produces a gradual increase in the abdominal girth from a break in the ducts or a ruptured pseudocyst that empties into the peritoneal cavity. This is diagnosed when the ascites fails to respond to diuretics and amylase levels remain elevated. That ERCP can be used to identify the disrupted duct, and then they can put stents in there. Pancreatic surgery may be required in certain cases. Then, as a complication, there are infections. Early infections occur 1 to 2 weeks after an attack and present with increased abdominal tenderness, high fever, leukocytosis, and bacteremia. These patients are septic with renal and respiratory failure. These infections spread through areas of necrosis and are often poorly defined. Late infections are related to abscesses in the areas of resolving necrosis or within a pseudocyst and may not appear until months after the attack. These present with abdominal pain and sepsis, but without pancreatitis, and you may need a CT scan to identify the area of necrosis and biopsies to identify the organisms. These early, poorly differentiated infections are treated surgically. Late infections or abscesses are drained, and antibiotic treatments are started with the identification of the organism. Now, pseudocysts are localized collections of pancreatic secretions that persist for more than 4 weeks. They are outside of the normal ductal system and are surrounded by fibrous tissue. The most common symptom is upper abdominal pain, in addition to early satiety and nausea and vomiting. They may enlarge rapidly and rupture, hemorrhage, generate ascites, obstruct the biliary tract, compress the inferior vena cava, corrode into surrounding structures, and become infected. You can see they're kind of bad actors. Treatment includes either surgery or percutaneous drainage. Then there are fistulas, and the symptoms of these include massive ascites or pleural effusions in patients with pancreatitis. They arise from a disruption of the pancreatic duct. They may communicate with the colon, gallbladder, small bowel, pleural space, mediastinum, bronchopulmonary tree, or the pericardium. Surgery, stenting, or decreasing pancreatic secretions with somatostatin are the treatments. Now, the pulmonary system can also get involved because abdominal pain and ascites limit the respiratory excursion, and fluid may accumulate within the pleural space and compress the lung. The most common cause of hypoxemia in these patients is ARDS. In the renal system, there's volume depletion and white cell emboli that may contribute to renal failure, or the kidneys may be involved by direct extension of inflammation or a pseudocyst. And if you remember, you can get prerenal because of the volume decretion, or intrarenal because of those white cell emboli. You can also get a GI hemorrhage. The stomach and duodenum are frequently involved in pancreatitis because they are in close proximity to the organ, and they can also bleed from erosive gastritis. The more serious bleeds include hemorrhage from an abscess or a pseudocyst that erodes into the vascular structures such as the splenic artery. Now, pancreatic inflammation can spread into the colon and cause perforation, and major complications involving the spleen are the extension of the inflammation or pseudocyst into the spleen. There can also be thrombosis of the splenic vein, which results in splenomegaly, or esophageal, gastric, or colonic varices that may rupture and bleed. Extension of a pseudocyst may lead to a splenic hematoma, and that can rupture. So if you haven't figured this out already, if these patients have several of these complications, they can be extremely ill. So how are we going to assess these people? Well, first of all is pain. The pain is usually located in the left upper quadrant, more towards the umbilicus, and may radiate to the low thoracic region of the back. It is a deep visceral pain that lasts for hours to days. And this deep pain is among the most severe and often leaves even the medicated patient writhing in discomfort. The pain decreases when sitting up in that fetal position and leaning forward. Nausea and vomiting is present in about 85% of patients. They also have diarrhea, usually a steatorrhea, if you remember that's the fatty fecal material. They have low-grade fevers, tachycardia, hypotension, abdominal tenderness, pleural effusions with dyspnea and tachypnea, mild jaundice. They may have Cullen's sign, which is a discolored periumbilicus, or Turner's sign, which is a discoloration of the flanks. So, how do we diagnose this? The first thing we look at is the amylase levels. An increased serum amylase results from both enhanced release of it into the blood and decreased renal clearance. Now remember, the normal serum amylase is about 60 to 160, and these serum amylases can rise above 500. Within the first few hours, both amylase and lipase are elevated, but after an attack, amylase falls faster, and that may last only 2 to 3 days. Lipase levels are much more reliable indicators in patients who are seen several days after the onset of their illness because it remains elevated maybe 7 to 10 days. And remember, that's involved in decreased calcium and magnesium levels. Now, the white blood cells are usually elevated. Platelets are usually decreased. There's an elevated BUN because of hemoconcentration related to third spacing. There can be the elevated glucose, and there also may be elevated LDH. Now, the imaging may include the abdominal ultrasound, a CT scan with contrast, or our ERCP, which remember that can exacerbate that acute pancreatitis. So they may use an MRCP, which is not as sensitive, but it's a lot safer. So now we're going to look at that ERCP. And that ERCP is an endoscopic retrograde cholangiopancreatography, which is why they only use the initials ERCP. In this procedure, an endoscope is passed via the esophagus into the stomach, through the pylorus, and into the duodenum. The papilla is then cannulated, followed by the bile duct. Then they shoot some contrast material in, and the x-rays are taken. And during this procedure, gallstones can be removed or stents can be placed. Now, write this down and highlight it. This procedure for nursing care is similar to caring for a patient with an EGD. So nursing care pre this ERCP involves the patient being NPO for 6 to 8 hours. You've got to assure that there's IV access for sedation. You want to especially check for allergies to contrast media. Remove any dentures. And you want to check for implantable devices, such as ICDs, because they cannot use the electrocautery tool in those instances. And determine if that patient has used NSAIDs, antiplatelet agents, or antihyperglycemic agents. And you want to notify the physician. Nursing care post, you want to take vital signs every 15 minutes until stable. And it's very important that you check for a gag reflex before giving them anything oral, because that patient may aspirate. Then you're going to DC the IV. Of course, you can't send them home with that. Of course, it can remain intact if you're in the hospital setting. And be sure to tell them that right after the procedure, they may have some colicky pain because of the instilled air that is happening through that endoscope, and that's to be expected. However, the patient must report any of the following that does not resolve if you're returning them home after outpatient procedure. If they have any abdominal pain, if they have fever, or if they have nausea and vomiting, they are to call the physician. And if it's done in an outpatient setting, they aren't supposed to drive for 12 to 18 hours because of the sedation. So, how do we treat this? Well, first of all, we're going to address their pain. And this is usually done with an opioid such as morphine or Dilaudid. They're really not using Demerol much anymore because they can end up causing seizures. There's a lot of fluid and electrolyte replacement because there is an analogy between severe pancreatitis and burns. And if you haven't studied burns yet, they require huge amounts of fluid for resuscitation. Albumin and blood products may be required in addition to the replacement of fluid and electrolytes with lactated ringers or other isotonic solutions. Metabolic abnormalities need to be corrected. Hyperglycemia is present in about 25% of patients with acute pancreatitis, But keep in mind there may be limited glucagon or glycogen reserves to respond to that hypoglycemia if you really get vigorous about treating the levels of glucose. You kind of want to be judicious with your insulin. Calcium levels may be decreased, and if they fall below 7.5, they're associated with poor prognosis. Hypocalcemia should be treated only when the patient is symptomatic. And if you remember, those symptoms are those painful muscle spasms in the calf, or if the patient has tingling or numbness in the extremities. Also, there's Trousseau's sign, or if you remember, if you wrap the blood pressure cuff and inflate it, you get spasms of the hand and the fingers. Or you have Chopstick sign, which you tap the side of the face in the front of the ear. You get twitching on one side of the mouth, nose, and chin. You also are going to use antibiotics, but they are usually discouraged except with the necrotizing pancreatitis. There may be that ERCP, because they are actually used to remove stones that are impacted at the ampulla, and if they can't remove it with the ERCP, there may be emergency surgery. Now, there's the NG tubes are put to low intermittent suction, but this is usually only done with severe vomiting. However, patients are NPO until they are starting to recover, and then the diet is small. It consists of high carb, high protein, low fat, bland, no caffeine, and no alcohol. Now, as far as therapeutic interventions for the nurse, you're going to want to obviously control their pain, and as I said before, they'll use the opioids. You may assist them into fetal positions because that also helps relieve the pain. Patients that are critically ill are going to be on complete bed rest, and they will be NPO to rest the GI tract until recovering. Intake and output are going to have to be done because the patients need an increase in fluids, usually isotonic. And you're going to check their glucose levels because of that disruption in insulin and glucagon secretion. Fluid volume deficits, which may be related to that vasodilation, you may have to monitor all that. And also do oral care because remember, they're NPO and they can have dry mucous membranes. They also may have ineffective breathing patterns related to pain, abdominal distension, and pleural effusions. And you want to observe for complications, including ascites and pulmonary complications, hopefully not ARDS, both pre- and intrarenal complications, hemorrhage from the gastritis or varices. They probably also have a knowledge deficit, so you're going to have to talk to them about the disease process so they can prevent any future attacks. And if they're older or without a support system, they may have altered home maintenance, which is the inability to care for themselves. You're going to want to get the home health care nurse involved. So how do you evaluate this? Well, first is their pain control. And then you want to look at their amylase and lipase levels and make sure that they're decreasing. And are any of those complications occurring? Did we control their nausea and vomiting? And does that patient really understand what's going on with them? So as far as patient teaching goes, again, you're going to have to tell them about the disease process. And besides, if they're consuming alcohol, especially if it's the thing that caused the disease process, you're going to have to tell them to knock it off. You're going to have to tell them to notify the MD, especially if they have acute abdominal pain, because it may indicate a recurrence of disease. If they experience jaundice, clay-colored stool, dark-colored urine, nausea or vomiting, fever greater than 100.4, or dizziness. You're also going to have to tell them that they must consume a low-fat diet and instruct them about all their medications, and by all means make sure they have a follow-up appointment.